Welcome to this video entitled, Community-Acquired Pneumonia. Pneumonia is an infection of the gas-exchanging units of the lung and has a wide spectrum of clinical severity, ranging from mild outpatient illness to severe respiratory failure and sepsis. Together, pneumonia and influenza are the 8th leading cause of death in the United States and the #1 cause of death from infectious diseases. Pneumonia in the community setting or within 48 hours following admission is termed community-acquired pneumonia, abbreviated as CAP. The community also includes patients with exposure to the healthcare environment, and pneumonia in such patients is referred to as healthcare-associated pneumonia, abbreviated as HCAP. Some, but not all, patients with HCAP are at risk for infection by multidrug-resistant (MDR) pathogens and may require empiric broad-spectrum antibiotic therapy, but many can be managed with therapy directed against community-acquired pneumonia pathogens. There has been increasing scrutiny by the Centers for Medicare and Medicaid Services on public reporting of outcomes and quality measures related to community-acquired pneumonia. Pneumonia patients requiring mechanical ventilation, abbreviated as MV, or invasive vasopressor support are generally considered as having severe community-acquired pneumonia, abbreviated as SCAP. However, there is no uniform definition for severe community-acquired pneumonia, and in the absence of these two factors, it is challenging to define severe pneumonia. Severity assessment scores may identify high-risk patients and help with site-of-care decisions, since a delay at the intensive care unit (ICU) level of care for patients with severe pneumonia is associated with worse outcomes. Biomarkers such as procalcitonin, abbreviated as PCT, are increasingly being used to identify patients with bacterial pneumonia and, along with severity assessment scores, may help identify high-risk patients and assist antimicrobial stewardship and de-escalation. We will now focus on the incidence of community-acquired pneumonia. The annual incidence of pneumonia ranges from 5 to 11 per 1,000 population, and the majority of patients are treated out of the hospital. However, the major portion of the cost of treatment is focused on hospitalized patients, particularly those admitted to critical care units. In addition, those with comorbid illness and those of advanced age make up a large proportion of the hospitalized, critically ill community-acquired pneumonia patients, and pneumonia in this population causes significant morbidity and mortality. Although community-acquired pneumonia can vary from being a mild to a severe illness, very few hospitalized patients are severely ill enough to require ICU admission. Torres et al. Specifically examined all ICU admissions over a 4-year period and noted that 10% were related to community-acquired pneumonia. In this group, 42% were admitted directly to the ICU, 37% came to the ICU after admission to another ward, and 21% came after transfer from another hospital. The time to ICU admission may have an impact on subsequent prognosis. Woodhead et al. Found that community-acquired pneumonia accounted for 5.9% of all ICU admissions and that early admission, within 2 days of hospitalization, was associated with a lower mortality, 46.3%, than late admission, that is more than 7 days in the hospital. 50.4% mortality. Recently, Restrepo and colleagues also noted a higher mortality among community-acquired pneumonia patients admitted to the ICU after 48 hours as compared with direct admission or within 24 hours, even after adjustment for the severity of illness, that is 47.4% versus 23.2%. With a p-value equal to 0.02. The economic liability associated with community-acquired pneumonia remains significant, at more than $17 billion annually in the United States. Kaplan and colleagues evaluated the cost of care for 623,718 elderly patients with community-acquired pneumonia in the United States and found that 2/3 of the population had one or more underlying illnesses, with congestive heart failure, the most common comorbidity, present in 32%. The overall mortality rate was 10.6%. But rose higher with advancing age, nursing home residence, and comorbid illness. The mean length of stay, abbreviated as LOS, was 7.6 days, and the costs generally paralleled the length of stay, but were disproportionately high for those needing mechanical ventilation. Cosma and colleagues, in a study of around 1.5 million community-acquired pneumonia admissions, showed a potential economic benefit of $2,300 per one less day spent in the hospital per patient. Other studies of community-acquired pneumonia have reported that costs are higher for patients with comorbid illness than for those without, but in those without comorbid illness, the cost for those who died was less than for those who survived, while the opposite was true when the entire community-acquired pneumonia population was considered. We will now discuss risk factors for developing severe community-acquired pneumonia. In all studies of community-acquired pneumonia, patients who were admitted to the hospital or ICU commonly had a number of coexisting illnesses, suggesting that individuals who are chronically ill have an increased risk of developing severe illness, as shown in Table 74.1. In studies of severe community-acquired pneumonia, serious coexisting illness was present in 46% to 66% of all patients. The common chronic illnesses in these patients are respiratory disease, cardiovascular disease, and diabetes mellitus. The most common respiratory illness in community-acquired pneumonia patients is chronic obstructive pulmonary disease, abbreviated as COPD, a finding that applies to those with either the mild or severe forms of community-acquired pneumonia. Cigarette smoking has been identified as a risk factor for bacteremic pneumococcal infection, especially in younger patients with fewer comorbid conditions, and current smoking status is associated with a higher mortality in community-acquired pneumonia patients than in non-smokers or ex-smokers. Other common illnesses associated with community-acquired pneumonia include malignancy, neurologic illness, including seizures, and acquired immune deficiency syndrome, AIDS. One study identified alcohol abuse as a risk factor, along with the failure to receive antibiotic therapy before hospital admission, which suggests that a delay in therapy may convert milder forms of pneumonia into a more severe illness. Genetic differences in the immune response may predispose certain individuals to more severe forms of infection and adverse outcomes. Further, use of inhaled corticosteroids is related to an increased risk of developing serious pneumonia compared to placebo. We will now focus on prognostic factors of community-acquired pneumonia. In recent years, there has been a trend toward increased hospitalizations in patients with a diagnosis of community-acquired pneumonia, especially in the elderly and those with comorbid diseases, who may also have higher mortality. Various studies have pointed out a high inpatient mortality among community-acquired pneumonia patients ranging from 12.1% to 24.4% and an even higher mortality in patients admitted to ICUs. Lately, investigators from the Community-Acquired Pneumonia Organization, abbreviated as CAPO, International Cohort Study reported mortality differences among patients hospitalized for community-acquired pneumonia, with a higher frequency of deaths in Latin America, that is 13.3%, compared with Europe, that is 9.1%, and the United States, that is 7.3%. In a meta-analysis of 33,148 patients with community-acquired pneumonia, the overall mortality rate was 13.7%, but those admitted to the ICU had a mortality rate of 36.5%. Factors associated with increased mortality in hospitalized community-acquired pneumonia patients included male sex, pleuritic chest pain, hypothermia, systolic hypotension, tachypnea, diabetes mellitus, neoplastic disease, neurologic disease, bacteremia, leukopenia, and multilobar infiltrates. Metesky and colleagues evaluated factors predicting in-hospital versus post-discharge mortality in 21,223 Medicare patients, 65 years old or older, admitted with a diagnosis of pneumonia. The authors noted a mortality of 12.1% within 30 days of admission, that is 52.4% of the deaths occurred during the hospital stay, and in-hospital mortality was higher in patients requiring mechanical ventilation on admission, and who had bacteremia, hypotension, blood pressure of less than 90 mm of mercury systolic, respiratory rate of greater than 30 beats per minute, pH of less than 7.35, and renal failure. Of note, the timing of death, early versus late, was unrelated to baseline patient demographic factors or comorbidities, but in-hospital mortality was related to the severity of illness. In other studies, the clinical features that predicted a poor outcome, as shown in Table 74-2, included advanced age, above 65 years, pre-existing chronic illness of any type, the absence of fever on admission, respiratory rate greater than 30 breaths per minute, diastolic or systolic hypotension, elevated blood urea nitrogen, BUN above 19.6 mg per deciliter, profound leukopenia or leukocytosis, inadequate antibiotic therapy, need for mechanical ventilation, hypoalbuminemia, and the presence of certain high-risk organisms, type 3 pneumococcus, Staphylococcus aureus, gram-negative bacilli, aspiration organisms, or post-obstructive pneumonia. One study of 3,233 patients in Spain found that risk factors for all-cause mortality included a higher severity of illness on admission, the need for ICU care, and the presence of multilobar infiltrates. However, late mortality, after at least 3 days, was reduced if blood cultures were negative, antibiotic therapy was consistent with guidelines, and if an etiologic agent was identified. In another prospective study of 1166 severe community-acquired pneumonia patients from 17 different countries, factors related to mortality at 28 days and at the 6-month follow-up were higher acute physiology and chronic health evaluation 2, abbreviated as APACHE, 2 scores, lower hematocrit, and the need for mechanical ventilation, and lower pH on arterial blood gas analysis predicted early mortality. Other studies have noted that an elevated red cell distribution with alone or in combination with elevated BUN equal to or greater than 30 mg per deciliter, was related to increased 90-day mortality and a complicated hospital course in community-acquired pneumonia patients, likely reflecting the inflammatory suppression of erythropoiesis in severe infection. In general, the severity of illness on admission affected early mortality the most, while therapy-related, modifiable risk factors affected late mortality. Preener and colleagues noted a biphasic relationship between platelet count and mortality in hospitalized community-acquired pneumonia patients, with increased mortality once the count was outside the range of 100,000 to 400,000 per millimeter cubed. The authors noted more respiratory complications, such as empyema and pleural effusion in patients with thrombocytosis, platelet count equal to or greater than 4 times 10 power 5 per millimeter cubed, than in those without thrombocytosis. On the other hand, those with thrombocytopenia, platelet count equal to or less than 10 power 5 per millimeter cubed, had higher rates of severe sepsis, septic shock, invasive mechanical ventilation, and ICU admission than the rest of the population. In another study, Lasener and associates observed a biphasic relationship when relating community-acquired pneumonia mortality to arterial partial pressure of carbon dioxide, abbreviated as PaCO2, on admission, with both hypercapnia, PaCO2 less than 35 mm of mercury, and hypercapnia, PaCO2 greater than 45 mm of mercury, being risk factors for high 30-day mortality and a higher need for ICU admission compared with patients with a normal PaCO2, even after excluding patients with COPD. As with other acute severe infections, any delay in treatment or admission to the ICU in patients with severe community-acquired pneumonia can lead to higher rates of complications and increased mortality. Several studies have noted an increased mortality when community-acquired pneumonia patients have a delay in the initiation of appropriate antibiotic therapy, with most studies using an average of 6 hours since being first evaluated in the emergency room as the cutoff value. Renaud et al. In a study of 453 community-acquired pneumonia patients, noted that the 28-day mortality was 11.7% for those with an obvious need for ICU care who were directly admitted to the ICU, which was significantly lower than the 23.4% mortality rate of those without obvious need for ICU care and had delayed admission. Rayek and associates divided community-acquired pneumonia patients into those requiring mechanical ventilation within 72 hours of the onset of community-acquired pneumonia and those with progressive respiratory failure requiring invasive mechanical ventilation 4 or more days after the onset of community-acquired pneumonia. There was a significant difference in mortality between the early respiratory failure group compared with the late respiratory failure group, that is 28% versus 51%, with a p-value equal to 0.03, suggesting that a delay in the identification of respiratory failure, transfer to ICU, or the development of progressive symptoms have deleterious effects on patient outcome. In a study evaluating early cardiac events, including myocardial infarction and cardiac arrest in 55,276 patients, Carr and colleagues noted that 8% of cardiac arrest cases occurred in pneumonia patients. In this population, 62% of cardiac arrests occurred in patients admitted to the ICU, and only about 50% were on vasopressors or required mechanical ventilation. Cardiac arrest occurred earlier in the ICU than in the ward, at a median of 18.9 versus 28.4 hours, and was generally not a shockable rhythm, asystole or pulseless electrical activity. These findings suggest that patients with community-acquired pneumonia in the hospital, or even the ICU, commonly have cardiac ischemia and that the event may be abrupt and without warning, potentially causing cardiorespiratory arrest. In another study, a restrictive red blood cell transfusion strategy, target hemoglobin level 7 to 9 grams per deciliter in all patients, except those with acute myocardial infarcts or unstable angina, was associated with better outcomes for community-acquired pneumonia patients. When these findings are viewed together, they suggest some general principles. Mortality is more likely in community-acquired pneumonia patients who have severe physiologic derangements, serious underlying illnesses, a delay in the initiation of appropriate antimicrobial therapy or mechanical ventilation, and the presence of atypical clinical features. This last factor suggests that an unusual clinical presentation, low fever, non-distinct respiratory symptoms, is associated with mortality, which may be the result of its reflecting an inadequate inflammatory response to infection, and because it can also lead to a delay in the recognition of pneumonia and the institution of appropriate therapy. Pause the video and carefully scrutinize Table 74(1) summarizing risk factors for developing severe community-acquired pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 74(2) summarizing risk factors for a poor outcome from community-acquired pneumonia before advancing to the next slide. We will now focus on the pathogenesis of community-acquired pneumonia. Pneumonia results when host defenses are overwhelmed by an infectious pathogen. This may occur because the patient has an inadequate immune response, often as the result of underlying comorbid illness, anatomic abnormalities, acute illness-associated immune dysfunction, or therapy-induced dysfunction of the immune system. Pneumonia can also occur in patients who have an adequate immune system if the host defense system is overwhelmed by a large inoculum of microorganisms, or if the patient encounters a particularly virulent organism to which he or she has no pre-existing immunity, or to which the patient has an inability to form an adequate acute immune response. Microaspiration of infected oropharyngeal secretions is the most common mechanism associated with pneumonia. Other routes of entry include inhalation, which applies primarily to viruses, Legionella pneumophila, Mycobacterium tuberculosis, hematogenous dissemination from extrapulmonary sites of infection, right-sided endocarditis, and direct extension from contiguous sites of infection, such as liver abscess. Thus, previously healthy individuals develop infection with virulent pathogens such as viruses, Legionella pneumophila, Mycoplasma pneumoniae, Chlamydophila pneumoniae, and Streptococcus pneumoniae. On the other hand, chronically ill patients can be infected by these organisms, as well as by organisms that commonly colonize patients, but only cause infection when immune responses are inadequate. These organisms include enteric gram-negative bacteria, e.g., Escherichia coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter species, and fungi. Studies that have evaluated the normal lung immune response to infection have shown that in most patients with unilateral community-acquired pneumonia, the inflammatory response is limited to the site of infection. In patients with localized pneumonia, tumor necrosis factor alpha, TNF-alpha, interleukin, IL-6, and IL-8 levels were increased in the pneumonic lung and generally not increased in the uninvolved lung or in the serum. On the other hand, in patients with severe pneumonia, the immune response is characterized by spillover of the immune response into the systemic circulation, reflected by increases in the serum levels of TNF-alpha and IL-6. It remains uncertain why localization does not occur in all individuals and why some patients develop diffuse lung injury, e.g., acute respiratory distress syndrome, abbreviated as ARDS, or systemic sepsis as a consequence of pneumonia. These complications may result from an inability to develop a brisk lung immune response as a consequence of specific bacterial virulence factors, inadequate or delayed therapy, or genetic polymorphisms that affect the immune response. Pneumonia-associated inflammation may also impact the long-term mortality and cognitive decline in community-acquired pneumonia patients. We will now discuss the clinical features of community-acquired pneumonia. Symptoms and physical findings. Patients with community-acquired pneumonia and an intact immune system have a normal pulmonary response to infection and generally have respiratory symptoms such as cough, sputum production, and dyspnea, along with fever and other complaints. Cough is the most common finding and is present in up to 80% of all patients, but is less common in those who are elderly, those with serious comorbidities, or patients coming from nursing homes. Pleuritic chest pain is also common in patients with community-acquired pneumonia, and in one study, its absence was also identified as a poor prognostic finding. The elderly generally have fewer respiratory symptoms than younger individuals, and as mentioned, the absence of clear-cut respiratory symptoms and an afebrile status are themselves predictors of an increased risk of death. In elderly patients, pneumonia can have a non-respiratory presentation, with symptoms of confusion, falling, failure to thrive, altered functional capacity, or deterioration in a pre-existing medical illness, such as congestive heart failure. Physical findings of pneumonia include tachypnea, crackles, rhonchi, and signs of consolidation, manifesting as egophony, bronchial breath sounds, and dullness to percussion. Patients should also be evaluated for signs of pleural effusion. In addition, extrapulmonary findings should be sought to rule out metastatic infection, arthritis, endocarditis, meningitis, or to add to the suspicion of an atypical pathogen, such as Mycoplasma pneumoniae or Chlamydia pneumoniae, which can lead to complications such as bullous meningitis, rash, pericarditis, hepatitis, hemolytic anemia, or meningoencephalitis. In the elderly, an elevation of respiratory rate can be the initial presenting sign of pneumonia, preceding other clinical findings by as much as 1 to 2 days. In fact, in one study, tachypnea was the most common finding in elderly patients with pneumonia, being present in over 60% of all patients and occurring more often in the elderly than in younger patients with pneumonia. Radiographic features. For most patients, community-acquired pneumonia is defined by a combination of clinical symptoms and the presence of a new radiographic infiltrate, but not all patients with this illness will have this finding when first evaluated. Even when the radiograph is negative, if the patient has appropriate symptoms and focal physical findings, pneumonia may still be present. Although some studies have suggested that febrile and dehydrated patients can have a normal chest radiograph when first admitted with pneumonia, the idea of hydrating pneumonia is in the realm of conventional wisdom and anecdotal reports. The presence of alveolar densities, lobar or bronchopneumonic, has been associated with a high likelihood of a bacterial etiology, but it is extremely difficult to distinguish among specific pathogens using patterns of radiographic abnormalities. Chest radiographs may have prognostic value in patients with severe pneumonia, multilobar infiltrates, or rapid progression of infiltrates serving as poor prognostic signs, helping to identify patients who require intensive care. Computed tomography, CT, scan of the chest generally has a higher sensitivity in diagnosing occult pneumonia with an initially negative chest radiograph. Chest CT can also have value in the critically ill patient in situations when a non-infectious process is being considered or when complications such as pneumothorax, empyema, or abscess are suspected. CT can suggest certain alternative non-infectious diagnoses such as granulomatous vasculitis, acute eosinophilic pneumonia, and bronchiolitis obliterans with organizing pneumonia. Lung ultrasound, abbreviated as LUS, denotes a new technique that has increasingly been adopted for diagnosing pleural and pulmonary diseases. Various patterns with B and M mode ultrasound techniques, including tissue sign, shred or fractal sign, and dynamic air bronchograms, are seen with pulmonary consolidation, whereas the sinusoidal sign and quad sign are seen with even small pleural effusion. In a prospective, multi-center study including 362 patients with suspected community-acquired pneumonia, lung ultrasound was found to have a sensitivity of 93.4% and specificity of 97.7% compared with chest X-ray and chest CT. In that study, the combination of lung ultrasound and auscultation decreased the negative likelihood ratio to 0.04, with a 95% confidence interval of 0.02 to 0.09. But the technique is operator dependent, and about 8% of pneumonic lesions are not visualized by lung ultrasound. The non-invasive nature of the test and rapidity with which it can be performed make this test another tool in the armamentarium for critical care physicians, and a recent meta-analysis of 10 studies with 1172 patients supports the use of lung ultrasound by skilled practitioners. We will now focus on severity scoring in community-acquired pneumonia. Although there is no uniformly accepted definition for severe community-acquired pneumonia, this term generally refers to any patient who is admitted to the ICU because of community-acquired pneumonia. Most of these patients have severe sepsis or respiratory failure, which is defined by the presence of hypoxemia or hypercarbia, and not all such patients require mechanical ventilation. Some patients with community-acquired pneumonia are treated in the ICU because the pneumonia has led to clinical instability of an underlying disease, but the pneumonia itself may not be severe. Bacteremia does not always correlate with more severe illness, and its presence alone is not always a predictor of a poor outcome, with most episodes of bacteremia being due to pneumococcus. However, in the elderly with pneumococcal pneumonia, bacteremia is present in 1/4 of patients with community-acquired pneumonia and is often associated with azotemia and multilobe involvement. When an infection such as pneumonia is complicated by severe sepsis or septic shock, not just bacteremia, the outcome is adversely affected, with increases in mortality, length of stay and costs for survivors. One approach to evaluating community-acquired pneumonia patients is to use a scoring system to define prognosis and predict the risk of death. The most widely used prognostic scoring systems are the Pneumonia Severity Index, abbreviated as PSI, and a modification of the British Thoracic Society, abbreviated as BTS, scoring system, the CAB-65 score. Other prediction rules, such as the American Thoracic Society, ATS, Infectious Diseases Society of America, IDSA, criteria for severe community-acquired pneumonia, the Australian SMART COP, the Japanese A-DROP scoring system, CAP-PIRO, and the Spanish CUR-XO80 have also been developed for risk prognostication and to help with appropriate resource utilization. The investigators in the Pneumonia Outcomes Research Team, abbreviated as PORT, study developed a mortality prediction rule that classifies all patients into one of 5 groups, PSI classes 1 to 5, each with a different level of risk for death. Patients in classes 4 and 5 have predicted mortality risks of 8.2% to 9.3% and 27% to 31.1%, respectively, whereas those in classes 1 and 2 have predicted mortality risks of 0.1% to 0.4% and 0.6% to 0.7%, respectively. To use this scoring system, patients have points calculated based on factors such as age, sex, the presence of comorbid medical disease, certain physical findings, and laboratory data. While the PORT scoring system has been shown to be accurate for predicting mortality and prognosis, it does not directly measure the severity of illness, and a poor correlation has been found between mortality and the need for ICU admission. In a study evaluating patients in PORT Class 5, only about 20% needed ICU admission, and they had an overall mortality of 37%, compared with the 20% mortality of the Psi-5 patients who did not need the ICU. In general, the Psi-5 patients who needed the ICU tended to get more of their points from acute illness, whereas those not needing the ICU tended to score points because of chronic disease factors. In addition, in young patients without comorbid illness, the pneumonia must be particularly severe to place the patient in a high mortality risk group, and certain vital sign thresholds must be exceeded to accumulate points toward a poor prognosis. For the critical care physician, underestimating the severity of illness is a more serious concern, and the use of the CAB-65 approach, modified from the BTS rule, is a simple and accurate way to address this issue. CAB-65, an acronym for the clinical features used to assess pneumonia severity and prognosis, assigns 1 point, on a 5-point scale, to confusion, blood urea greater than 7 millimoles per liter, respiratory rate greater than or equal to 30 breaths per minute, blood pressure of less than 90 millimeters of mercury systolic or equal to or less than 60 millimeters of mercury diastolic, and age greater than or equal to 65 years. In one study, when the score was 0 to 1, the mortality rate was 0%, whereas the mortality was more than 20% for a score of 3 or higher, and those with a score of 2 had a mortality of 8.3%. The use of the CAB-65 rules may be a problem in the elderly, reflecting the altered clinical presentations of pneumonia in this population. Interestingly, although the rule was not optimal in an elderly population and did not work as well as it did in other populations, it had a higher sensitivity for predicting mortality than the Pneumonia Severity Index, which is derived from the PORT study. Some studies have compared the Pneumonia Severity Index and CAB-65 and found them to be similar for identifying low-risk populations. However, the CAB-65 may be better at identifying poor prognosis in those with severe illness, compared with the Pneumonia Severity Index. An amended version of the CAB-65 that does not use the laboratory measurement of BUN, known as the CRB-65, has also been found to be similarly accurate. In another study comparing the performance of Pneumonia Severity Index and CAB-65 risk scores, the discriminatory power for 30-day mortality, using both Pneumonia Severity Index and CAB-65, was lower in healthcare-associated pneumonia than in community-acquired pneumonia patients. Other prognostic scoring systems have been developed to define the presence of severe pneumonia. Espana and Associates estimated the need for ICU admission by the presence of one of two major criteria: arterial pH less than 7.30 or systolic blood pressure less than 90 millimeters of mercury. In the absence of these criteria, severe community-acquired pneumonia can also be identified by the presence of 2 of 6 minor criteria, including confusion, BUN greater than 30 mg per deciliter, respiratory rate above 30 per minute, PaO2 to FiO2 ratio less than 250, multilobar infiltrates, and an age of at least 80 years. When these criteria were met, the tool was 92% sensitive for identifying those with severe community-acquired pneumonia and was more accurate than the Pneumonia Severity Index or CAB-65 criteria, although not quite as specific as the CAB-65 rule. Using this approach, some criteria, acidosis and systolic hypotension, are weighted more heavily than others, which contrasts with some of the other approaches to define severe community-acquired pneumonia. A different method than assessing risk for death is to use scoring systems to define the need for ICU interventions such as intensive respiratory and vasopressor support, abbreviated as IRVS. The SMART COP tool was developed to predict the need for intensive respiratory and vasopressor support. Using a multivariate model, there were 8 clinical features associated with the need for intensive respiratory and vasopressor support: systolic blood pressure less than 90 mm of mercury, multilobar infiltrates, albumin less than 3.5 grams per deciliter, respiratory rate elevation greater than 25 breaths per minute for those aged 30 breaths per minute for those aged above 50 years, tachycardia, greater than 125 beats per minute, confusion, low oxygen, 50 years, and arterial pH less than 7.35. Abnormalities in systolic blood pressure, oxygenation, and arterial pH each received 2 points, while the 5 other criteria received 1 point each, and with this system, the need for IRVS was predicted by a SMART COP score of at least 3 points. Using this cutoff, the sensitivity for need for IRVS was 92.3% and the specificity was 62.3%, with positive and negative predictive values of 22% and 98.6%, respectively. The Pneumonia Severity Index and CAB-65 did not perform as well overall for predicting the need for IRVS. The most recent ATS/IDSA guidelines for community-acquired pneumonia suggested that ICU care be considered if the patient has one of 2 major criteria: need for mechanical ventilation or septic shock with the need for vasopressors, or 3 of 9 minor criteria. The minor criteria include respiratory rate greater than 30 breaths, min, PaO2 to FiO2 ratio below 250, multilobar infiltrates, confusion, disorientation, uremia, VUN level above 20 mg per deciliter, leukopenia, white blood cell count below 4,000 cells per millimeter cubed, thrombocytopenia, platelet count below 100,000 cells per millimeter cubed, hypothermia, core temperature below 36 degrees Celsius, and hypotension requiring aggressive fluid resuscitation. Other factors to consider in the decision-making process are hypoglycemia in a non-diabetic patient, hyponatremia, acute alcohol intoxication, cirrhosis, asplenia, and unexplained metabolic acidosis. The use of these minor criteria alone requires validation, with one study showing that patients who met only minor criteria for ICU admission did not have an increase in mortality, while in another study, the use of 4 minor criteria instead of 3 improved the accuracy in defining the need for ICU admission. Poor and colleagues showed that the ATS minor criteria had greater discriminatory power in the prediction of severity, ICU admission, and mortality than the Pneumonia Severity Index and CAB. Brown and Associates noted that both the positive and negative predictive values of the minor criteria exceeded 80% if 4 criteria were used to define the need for ICU admission rather than just 3 criteria. In a recent study, Investigators simplified the ATS/IDSA criteria by excluding variables that occurred in less than 7.35, improved the prediction for mortality and for ICU admission. Rello and Associates evaluated the CAP-PIRO score, calculated within 24 hours of ICU admission. In this study, 1 point was assigned for each variable: comorbidities, COPD, immunocompromised, age greater than 70 years, multilobar opacities on chest radiograph, shock, severe hypoxemia, acute renal failure, bacteremia, and ARDS. Patients were stratified into 4 levels of risk. 1. Low, 0 to 2 points. 2. Mild, 3 points. 3. High, 4 points. And 4. Very high, 5 to 8 points. The PIRO score performed well as a 28-day mortality prediction tool in patients with community-acquired pneumonia requiring ICU admission, with a better performance than Apache 2 and the ATS/IDSA criteria. The risk of early admission to ICU, rare ICU, index was derived from a dataset of nearly 5,000 patients and is helpful as a tool on admission to identify patients who had no obvious indication for ICU management, but subsequently required ICU care. It categorizes individuals into 4 risk groups based on 11 criteria independently associated with ICU admission: male gender, age younger than 80 years, comorbid conditions, respiratory rate of 30 breaths per minute or higher, heart rate of 125 beats per minute or higher, multilobar infiltrate or pleural effusion, white blood cell count less than 3 or 20,000 per liter or above, hypoxemia, oxygen saturation less than 90% or arterial partial pressure of oxygen, PaO2, less than 60 mm of mercury, BUN of 11 millimoles per liter or higher, pH less than 7.35, and sodium less than 130 milliequivalent per liter. The mortality and likelihood of needing ICU care increased with each successive risk group, with the highest in Class 4 with a score equal to or greater than 9. In a recent validation study including 850 community-acquired pneumonia patients who had no obvious need for ICU care on admission, the rare ICU index performed better than pneumonia severity index, but was similar to other tools, such as SMART-COP, CUR-X080, the 2007 ATS/IDSA severity criteria, and CAB-65, at defining the need for early ICU admission. The need for sensitive criteria to define severe illness in community-acquired pneumonia patients is important, since the benefit seems most certain if patients are admitted to the ICU early during the course of severe illness. We will now discuss the role of biomarkers in severe community-acquired pneumonia. The measurement of serum levels of biomarkers, such as C-reactive protein, midregional prodronomedulin, midregional proatrial natriuretic peptide, MR-pro-ANP, proarginine vasopressin, copeptin, proendothelin-1, or procalcitonin, may be valuable in guiding the management of antibiotics for community-acquired pneumonia. Procalcitonin is an acute phase reactant synthesized in the liver in response to bacterial, but not viral, infection. Studies on community-acquired pneumonia have documented that serial measurement of the levels of procalcitonin can guide the duration of antibiotic therapy, allowing cessation of therapy once levels fall and leading to a marked reduction in the duration of therapy compared with clinical judgment. In patients with severe community-acquired pneumonia, the measurement of initial and serial levels can help to identify those with a poor prognosis, and a low procalcitonin value may distinguish which patients in pneumonia severity index classes 4 and 5 might be safely managed out of the ICU. Kruger and colleagues reported that non-survivors had significantly higher median procalcitonin levels on admission than survivors, that is 0.88 versus 0.13 nanogram per milliliter, with a p-value equal to 0.0001. Low procalcitonin accurately predicted patients at very low risk of death, even in those patients in a high prognostic scoring category by CAB-65 evaluation. Given its high negative predictive potential, 98.9% with a procalcitonin level less than 0.228 nanogram per milliliter, patients with low initial procalcitonin might be safely treated out of the ICU. Huangov and colleagues found that 23.1%, that is 126 out of 546, of high-risk patients defined by Pneumonia Severity Index had low procalcitonin levels on the first hospital day, and this subgroup had very low mortality, similar to low-risk patients. In a prospective study of 685 community-acquired pneumonia patients, Ramirez and associates evaluated the relationship between biomarkers and ICU admission. Inflammatory biomarkers helped identify patients needing intensive care monitoring, including those requiring delayed ICU admission. No patient with equal to or greater than 3 ATS minor severity criteria and procalcitonin levels below the cutoff, that is 0.35 nanogram per milliliter, needed ICU admission compared with 14, that is 23%, with levels above the cutoff, with a p-value equal to 0.032. In another study, the authors compared the levels of three biomarkers: N-terminal pro-B-type natriuretic peptide, NT-pro-BNP, MR-pro-ANP, and B-type natriuretic peptide, BNP, with the Pneumonia Severity Index and CAB-65 scores for predicting short and long-term mortality. The levels of NT-pro-BNP, MR-pro-ANP, and BNP increased with the severity of pneumonia, and patients who died had higher levels of all three biomarkers. A combined assessment using categorical Pneumonia Severity Index score and NT-pro-BNP levels seemed beneficial over a single marker approach for short and long-term risk stratification. In a recent meta-analysis of 7 studies, including 1075 patients, using a procalcitonin-based regimen in patients with severe sepsis or septic shock, the 28-day mortality was not different between the procalcitonin-based regimen and standard treatment groups, but the procalcitonin-guided group had a shorter duration of antimicrobial therapy. Using a procalcitonin-based strategy led to more de-escalation and a shorter duration of antibiotic therapy, with no adverse effect on mortality. Using biomarkers to adjudicate severity is best done in conjunction with clinical, microbiological, and pathologic data. A combined approach including severity scores and biomarkers can aid clinicians in assessing the severity of the illness and the need for the use of antibiotics, and serial measurements can be used to assess the treatment response. However, procalcitonin or other biomarkers are not specific for pneumonia itself and can be elevated in other infectious or inflammatory conditions, and, thus, should be interpreted with caution in patients with cardiac and renal failure. We will now progress to etiologic pathogens. Even with extensive diagnostic testing, an etiologic agent is identified in only about half of all patients with community-acquired pneumonia, pointing out the limited value of diagnostic testing and the possibility that we do not know all the organisms that can cause community-acquired pneumonia. In the past 4 decades, a variety of new pathogens for this illness have been identified, including Legionella pneumophila, Chlamydia pneumoniae, Middle East Respiratory Syndrome coronavirus, abbreviated as MERS-CoV, avian origin influenza A, hydrogen nitride, novel H1N1, H3N2 influenza, and hantavirus. In addition, antibiotic-resistant variants of common pathogens, such as Streptococcus pneumoniae, have become increasingly common. However, recent data show a decreased ICU mortality in pneumococcal community-acquired pneumonia between 2000 and 2013, which likely reflects appropriate identification of severe community-acquired pneumonia, early antibiotic prescription, and increased use of combination therapy. The likely pathogens for infection vary depending on patient risk factors for specific microorganisms and the presence of certain comorbid illnesses, but for all patient groups, including those with severe community-acquired pneumonia, pneumococcus is the most common pathogen. The incidence of antibiotic-resistant pneumococci has increased in recent years, and up to 40% of these organisms can have reduced sensitivity to penicillin or other antibiotics, although the clinical relevance of in vitro resistance is still uncertain. Although Streptococcus pneumoniae is the most common organism causing community-acquired pneumonia, the frequency of pneumococcal pneumonia has declined, probably due to effective vaccination practices and a decreased incidence of smoking in adults. Identified risk factors for drug-resistant Streptococcus pneumoniae, abbreviated as DRSP, include beta-lactam therapy in the past 3 months, alcoholism, age older than 65 years, immune suppression, multiple medical comorbidities, and contact with a child in daycare. Other common infecting organisms in those with severe community-acquired pneumonia include viruses, e.g., influenza, respiratory syncytial virus, and the coronavirus illness of severe acute respiratory syndrome, abbreviated as SARS, Legionella pneumophila, Mycoplasma pneumoniae, Mycobacterium tuberculosis, and Haemophilus influenza, especially in smokers. In the setting of severe pneumonia, patients can be infected with Staphylococcus aureus, including methicillin-resistant forms, or MRSA, or enteric gram-negatives and, rarely, anaerobes. In the elderly, including those with aspiration pneumonia, healthcare-associated pneumonia and, in those with underlying cardiopulmonary disease, enteric gram-negative organisms are often seen. Although aspiration has often been considered a risk factor for anaerobic infection, studies of severe community-acquired pneumonia in elderly patients with aspiration risk factors have suggested that this population is very likely to have gram-negative infection. Risk factors for gram-negative organisms causing community-acquired pneumonia are probable aspiration, previous hospital admission within 30 days of admission, previous antibiotic use within 30 days of admission, the presence of pulmonary comorbidity, smoking, and hyponatremia. Falguera and Associates, in a study of 3,272 episodes of community-acquired pneumonia, found that 2% were caused by enteric gram-negatives, most commonly Pseudomonas aeruginosa, and the risk factors for these organisms were COPD, current use of corticosteroids, prior antibiotic therapy, tachypnea above 30 breaths per minute, and septic shock on admission. Patients with these organisms needed ICU care more often and had a higher mortality and longer length of stay than those without these pathogens present. Primary pulmonary infection with atypical pathogens has been reported for patients with severe community-acquired pneumonia for many years. In fact, in one ICU in Spain, Atypical pathogens were present in almost 25% of all patients, but the responsible organism varied over time. Legionella was the most common atypical pathogen, leading to severe community-acquired pneumonia in 14% of patients during one time period, but in the same hospital a decade later, it was seen in only 2% of patients, having been replaced by Mycoplasma and Chlamydophila infection, which were found in 17% of patients compared with only 6% a decade earlier. Several studies have shown that even if bacterial pathogens lead to community-acquired pneumonia, they can be accompanied by atypical pathogens in the form of mixed infection. Atypical pathogens can include Chlamydia pneumoniae, Mycoplasma pneumoniae, and Legionella pneumophila, and some studies have shown that these infections are common in patients of all ages, not just young and healthy individuals. These organisms have even been reported among the elderly in nursing homes. When mixed infection is present, it may lead to a more complex course and a longer length of stay than if a single pathogen is present, which may explain the increasing numbers of studies that show a reduction in community-acquired pneumonia mortality, including those in the ICU, when initial therapy provides coverage for these organisms, compared with regimens that do not. Interestingly, multiple retrospective studies of pneumococcal bacteremia have shown a reduced mortality when dual therapy, usually involving a macrolide, rather than monotherapy is used, raising the possibility that even these patients have mixed infection with atypical pathogens. The frequency of atypical pathogens can be as high as 60%, with as many as 40% of all community-acquired pneumonia patients having mixed infection. These high incidence rates have been derived by serologic testing, which is of uncertain accuracy. Atypical organism pneumonia may not be a constant phenomenon, and the frequency of infection may vary over the course of time and with geography. In the past, Staphylococcus aureus was an uncommon cause of community-acquired pneumonia, but it was capable of leading to severe pneumonia. In the past several years, a community-acquired strain of methicillin-resistant Staphylococcus aureus, abbreviated as CAMRSA, has emerged as a cause of severe community-acquired pneumonia, particularly in patients without a history of previous hospitalization or chronic illness, often as a complication of influenza infection. The organism can lead to a severe, bilateral, necrotizing pneumonia, often related to toxin production by the organism. This organism is distinct from the nosocomial strain of methicillin-resistant Staphylococcus aureus and is clonal in origin, usually due to the USA 300 strain. And now we will discuss risk factors for specific pathogens. Table 74.3 summarizes the common pathogens causing community-acquired pneumonia in hospitalized patients, including those admitted to the ICU. The classification is based on the presence of clinical risk factors for specific pathogens, referred to as modifying factors. The modifying factors for drug-resistant Streptococcus pneumoniae are age older than 65 years, beta-lactam therapy within the past 3 months, alcoholism, immune-suppressive illness, including therapy with corticosteroids, multiple medical comorbidities, and exposure to a child in daycare. For the patient with healthcare-associated pneumonia, infection by resistant gram-negatives and methicillin-resistant Staphylococcus aureus can occur, particularly if the patient has multiple risk factors, in addition to nursing home residence. These risk factors include severe illness, poor functional status, immune suppression, recent antibiotic therapy, and recent hospitalization in the past 3 months. In predicting the likely etiologic pathogens for those admitted to the ICU, patients are divided into a population at risk for pseudomonal infection and a population in whom this organism is unlikely to be present. The risk factors for Pseudomonas aeruginosa infection are structural lung disease, bronchiectasis, corticosteroid therapy, that is more than 10 mg prednisone per day, broad-spectrum antibiotic therapy for more than 7 days in the past month, and malnutrition. In a study of 935 patients admitted with community-acquired pneumonia or healthcare-associated pneumonia, the authors evaluated risk factors for infection with MDR pathogens according to the ATS/IDSA 2005 Healthcare-Associated Pneumonia Guidelines. 106 patients with at least one risk factor for MDR pathogens had more severe pneumonia on admission and a higher prevalence of severe sepsis compared with those without, that is 45% versus 29. With a p-value less than 0.001, 31% versus 21%, with a p-value equal to 0.001, and of all the risk factors, hospitalization in the preceding 90 days, odds ratio 4.87, and residence in a nursing home, odds ratio 3.55, were independent predictors of infection with a resistant pathogen and mortality. Table 74.4 shows that certain clinical conditions are associated with specific pathogens, and these associations should be considered in all patients when obtaining a history. Although a variety of radiographic patterns can be seen in pneumonia, specific findings generally cannot be used to predict the microbial etiology in community-acquired pneumonia, but there are certain patterns to keep in mind. Focal consolidation can be seen in infections caused by Pneumococcus, Klebsiella species, aspiration, especially if in the lower lobes or other dependent segments, Staphylococcus aureus, Haemophilus influenza, Mycoplasma pneumoniae, and Chlamydia pneumoniae. Interstitial infiltrates suggest viral pneumonia as well as infection due to Mycoplasma pneumoniae, Chlamydia pneumoniae, Chlamydophila psittaci, and Pneumocystis jirovecii. Lymphadenopathy with an interstitial pattern should raise concerns about anthrax, Francisella tularensis, and Chlamydophila psittaci, whereas adenopathy can be seen with focal infiltrates in tuberculosis, fungal pneumonia, anthrax, and bacterial pneumonia. Cavitation can be the result of an aspiration lung abscess, infection with Staphylococcus aureus or aerobic gram-negatives, including Pseudomonas aeruginosa, tuberculosis, fungal infection, aspergillus, nocardiosis, and actinomycosis. Pause the video and carefully scrutinize Table 74.3 summarizing the common pathogens causing community-acquired pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 74.4 summarizing clinical associations with specific pathogens before advancing to the next slide. We will now discuss features of specific pathogens. Let's begin with Streptococcus pneumoniae, the most common pathogen for community-acquired pneumonia. This organism is a gram-positive, lancet-shaped diplococcus, of which there are 84 different serotypes, each with a distinct antigenic polysaccharide capsule. 85% of all infections are caused by one of 23 serotypes, which are included in a polysaccharide vaccine. Infection is most common in the winter and early spring, which may be related to the finding that up to 70% of patients have a preceding viral illness. The organism spreads from person to person and commonly colonizes the oropharynx before it leads to pneumonia. Pneumonia develops when the colonizing organisms are aspirated into a lung that is unable to contain the aspirated inoculum. Bacteremia is present in up to 20% of hospitalized patients, and extrapulmonary complications include meningitis, empyema, arthritis, endocarditis, and brain abscess. The burden of pneumococcal disease is often underestimated, since most studies report the incidence of bacteremic or invasive pneumococcal disease. Said and colleagues, in a systematic review and meta-analysis, estimated the proportion of community-acquired pneumonia attributable to pneumococcus as 27.3% and, using urine antigen testing, helped diagnose an additional 11.4% of pneumococcal community-acquired pneumonia beyond conventional techniques. In that study, 24.8% of all cases were bacteremic, and it was more common among those with severe illness, no prior antibiotic use, and a positive human immunodeficiency virus, HIV, status. As mentioned elsewhere, there is also a trend toward improved survival with severe pneumococcal community-acquired pneumonia in the ICU due to improved antibiotic prescription practices and a decrease in smoking in recent years. 84 Since the mid-1990s, antibiotic resistance among pneumococci has become increasingly common, and penicillin resistance, along with resistance to other common antibiotics, macrolides, trimethoprim, sulfamethoxazole, selected cephalosporins, is present in over 40% of these organisms. Fortunately, most penicillin resistance is of the intermediate type, penicillin minimal inhibitory concentration, abbreviated as MIC, of 0.1 to 1 mg per liter, and not of the high-level type, penicillin MIC of 2 or more. Although the clinical impact of in vitro resistance is uncertain, one large database has data showing that only organisms with a penicillin MIC of more than 4 mg per liter can lead to an increased risk of death. Recently, the definitions of resistance have been changed for non-meningeal infection, with sensitive being defined by a penicillin MIC equal to or less than 2 mg per liter, intermediate as an MIC of 4 mg per liter, and resistant as an MIC equal to or greater than 8 mg per liter. While the clinical impact of resistance on outcomes such as mortality was hard to show using older definitions, with the new definitions of resistance, very few pathogens will be defined as resistant, but those that may affect the outcome. In a recent study including 118 patients using the new definition for resistance, there was no difference in 30-day mortality between the penicillin-susceptible and resistant groups. The penicillin-resistant group had a higher frequency of having received antibiotics within the past 2 weeks, but interestingly, it was the susceptible group who had a higher frequency of worse initial presentations such as ICU admissions and bacteremia. In this cohort, both groups received equally broad-spectrum antibiotics such as extended-spectrum cephalosporins, vancomycin, and carbapenem. The relationship between prior antibiotic use and subsequent pneumococcal resistance is well known, and prior therapy with macrolides, beta-lactams, and quinolones has been identified as a predisposing factor for subsequent resistance to the same class of antibiotic. The risk was no lower for therapy in the past 6 months compared with therapy in the past 1 month. Other studies have shown that quinolone therapy can predispose to subsequent pneumococcal resistance to this class of antibiotics. In another study of patients with pneumococcal bacteremia, pneumococcal resistance to beta-lactams, penicillins and cephalosporins, macrolides, and quinolones was more likely if the patient had received the same agent in the past 3 months. Although some studies have shown that discordant therapy of drug-resistant pneumococcus can be a risk factor for mortality, in one study, Discordant therapy was less likely if patients were treated with ceftriaxone or sfotaxime compared with other therapies. Thus, in clinical practice, resistance is not likely to affect the outcome, since current guidelines for severe community-acquired pneumonia recommend the use of these effective agents as empiric therapy. Macrolide-resistant pneumococci have also been described and can be either low or high-level resistant, depending on whether the mechanism of resistance is efflux or ribosomal alteration, respectively. Although high-level resistance may be clinically relevant, this is generally not an issue in the management of ICU community-acquired pneumonia, since all patients who receive macrolide therapy do so in combination with a highly active beta-lactam that is effective against pneumococcus, even if macrolide resistance is present. We will now progress to Legionella pneumophila. This small, weakly staining, gram-negative bacillus was first characterized after an epidemic in 1976 and can occur either sporadically or in epidemic form. Although multiple serogroups of the species Legionella pneumophila have been described, and these account for 90% of all cases of Legionnaire's disease, serogroup 1 is responsible for most cases. The other species that commonly causes human illness is Legionella mcdadae, which is waterborne and can emanate from air conditioning equipment, drinking water, lakes and river banks, water faucets, and shower heads. Infection is generally caused by inhalation of an infected aerosol generated by a contaminated water source. When a water system becomes infected in an institution, endemic outbreaks may occur. In its sporadic form, Legionella may account for 7% to 15% of all cases of community-acquired pneumonia, being a particular concern in patients with severe forms of illness. Recent studies show an increase in the reported cases of Legionella, especially in big cities like New York, and a higher incidence in diabetes patients and those from poor neighborhoods. The classic Legionella syndrome is characterized by high fever, chills, headache, myalgias, and leukocytosis. The diagnosis is also suggested by the presence of pneumonia with preceding diarrhea, along with mental confusion, hyponatremia, relative bradycardia, and liver function abnormalities, but this syndrome is usually not present. Symptoms are rapidly progressive, and the patient may appear to be quite toxic. This classic syndrome is not always present, so this diagnosis should always be considered in patients admitted to the ICU with community-acquired pneumonia and in those with rapidly progressive radiographic abnormalities. To establish this diagnosis serologically, it is necessary to collect both acute and convalescent titers. The urinary antigen test, abbreviated as UAT, is the single most accurate acute diagnostic test for Legionella, but is specific only for serogroup 1 infection. However, it does not detect other types of Legionella, so a negative finding cannot rule out this infection. In recent years, most cases have been diagnosed with urinary antigen, and there has been less reliance on serology and culture. With this increased reliance on urinary antigen test, the case fatality rate of Legionella has fallen, possibly reflecting diagnosis of less severe illness than in the past. We will now switch gears to Staphylococcus aureus. Staphylococcus aureus can lead to severe forms of community-acquired pneumonia, which can be necrotizing, develop cavitary pneumonia, and have hematogenous dissemination to multiple sites in the body. The organism can also seed the lung hematogenously from valvular vegetations in patients with right-sided endocarditis or from septic venous thrombophlebitis, from central venous catheter or jugular vein infection. When a patient develops post-influenza pneumonia, Staphylococcus aureus can lead to secondary bacterial infection and, in the United States, community-acquired methicillin-resistant Staphylococcus aureus have emerged, primarily in skin and soft tissue infections, but also as a cause of severe community-acquired pneumonia. Community-acquired methicillin-resistant Staphylococcus aureus is a clonal disease, emanating from the USA 300 clone of Staphylococcus aureus, and is clinically and bacteriologically different from the strains of methicillin-resistant Staphylococcus aureus that cause nosocomial pneumonia. In addition, it can infect previously healthy individuals, and the classic clinical presentation of this pathogen causing community-acquired pneumonia is as a complication of a preceding viral or influenza infection. This illness is characterized by a severe, bilateral, necrotizing pneumonia, which may be related to staphylococcal virulence factors such as Pantin-Valentine leukocidin, abbreviated as PVL. In a prospective study of 627 patients from 12 emergency departments across the United States during 2 influenza seasons, the authors isolated community-acquired methicillin-resistant Staphylococcus aureus from 2.4% of all patients and 5% of patients admitted to the ICU. The mortality rate was 14%. And all isolates were of the USA 300 strain. Community-acquired methicillin-resistant Staphylococcus aureus patients had severe infection with multiple infiltrates or cavities on chest imaging, were intubated or required vasopressors, and, compared with other patients, were more likely to develop illness after nursing home admission in the previous year or after close contact in the previous month with someone with a skin infection. Since the pathogenesis of pneumonia due to this organism may be related to toxin production by the bacteria, therapy may need to involve both an antibacterial agent and an antitoxin-producing agent. Seco and Associates, in a study of 133 patients with Pantin-Valentine leukocidin-positive community-acquired pneumonia, found similar mortality rates between patients who had methicillin-resistant Staphylococcus aureus and methicillin-susceptible Staphylococcus aureus. However, treatment with antibiotics with antitoxin effects, clindamycin, rifampin, and linezolid, was associated with a reduced mortality compared with those who did not receive antitoxin therapy, that is 6.1% versus 52.3%, with a p-value less than 0.001, although only about 1/3 of patients received this therapy. The frequency of this illness is still relatively low, but it does occur sporadically, with certain geographic areas having a high frequency, especially during influenza season. We will now focus on other organisms. The incidence of viral pneumonia is difficult to define, but one careful study of over 300 non-immunocompromised community-acquired pneumonia patients looked for viral pneumonia by paired serologies and found that 18% had viral pneumonia, with about half being pure viral infection and the others being mixed with bacterial pneumonia. Influenza, A more than B, parainfluenza, and adenovirus were the most commonly identified viral agents. Viral illnesses that can lead to respiratory failure, in addition to influenza, include respiratory syncytial virus, which can affect the elderly, varicella, a particular concern in pregnant females with chickenpox, and hantavirus, endemic in the Four Corners area of New Mexico. In a recent study in patients with severe pneumonia using polymerase chain reaction (PCR) techniques, the authors found viral infection to be common. 36.4%, N equals 72, had positive viral markers, and 9.1%, N equals 18, had bacterial and viral co-infections. It is important to always consider the diagnosis of tuberculosis in patients with severe community-acquired pneumonia and fungal infections with coccidioidomycosis and histoplasmosis in endemic areas, especially in HIV-infected persons. Several rickettsia can also cause community-acquired pneumonia, including Q fever, Coxiella burnetii, which occurs worldwide, Rocky Mountain spotted fever, abbreviated as RMSF, and scrub typhus, Rickettsia tsutsugumushi, in Asia and Australia. Transmission typically involves an intermediate vector, often ticks, Q fever, Rocky Mountain spotted fever, or mites, scrub typhus, but also sheep, cows, and contaminated milk, Q fever. These infections have a variable incubation period, ranging from days to a few weeks, and are characterized by a febrile syndrome that may have a pneumonic component and a maculopapular rash, Q fever and Rocky Mountain spotted fever. We will now take a closer look at influenza. Influenza should always be considered during epidemic times and can lead to primary viral pneumonia or to secondary bacterial infection with pneumococcus, Staphylococcus aureus, or Haemophilus influenza. In April 2009, an outbreak of H1N1 influenza infected approximately 61 million people worldwide, with as many as 13,000 deaths. H1N1 influenza, in contrast to seasonal flu, affected younger people more than the elderly, and high-risk populations included pregnant women and those with obesity. In one series, 12% of all hospitalized patients with H1N1 infection were administered mechanical ventilation, and 6% of hospitalized patients died. Antiviral therapy with zanamivir and oseltamivir may reduce the severity of illness, particularly if given early, and the role of corticosteroids for patients with severe illness is controversial. The frequency of documented bacterial pneumonia complicating this illness varies from 25% of patients with radiographic pneumonia. Muscadere and Associates evaluated the risk of coexistent or secondarily acquired bacterial respiratory tract or bloodstream positive cultures in 681 patients with 2009 influenza A, hydrogen nitride, infection. In that study, 38% of patients had at least a positive blood or respiratory culture during their ICU stay. Although almost all the patients received antibiotics, patients with any positive cultures had higher morbidity, with more days on the ventilator, longer ICU and hospital length of stay, and higher hospital mortality compared with those with negative cultures. Recently, during the spring of 2013, infection with novel avian origin influenza A, hydrogen nitride, emerged in China and was related to exposure to live animals, including chickens, 82%. It was linked with a high incidence of respiratory failure and ICU admission, especially in those with comorbid conditions, and mortality ranged from 27% to 34% among ICU patients. We will now discuss severe acute respiratory syndrome. In late 2003, a respiratory viral infection, caused by coronavirus, emerged in parts of Asia and was termed severe acute respiratory syndrome. The illness affected people from a variety of endemic areas in Asia, but was seen in North America when an outbreak occurred in Toronto, Canada. Importantly, worldwide, as many as 20% of affected patients were healthcare workers, particularly those caring for patients admitted to the ICU. Transmission risk was greatest during emergent intubation, and was also possible during non-invasive ventilation, making this latter modality of therapy contraindicated if severe acute respiratory syndrome is suspected. Infection control may be quite effective in preventing the spread of severe acute respiratory syndrome to healthcare workers and includes the careful handling of respiratory secretions, ventilator circuits, the use of N95 respirator masks, and careful gowning and gloving. Even more elaborate infection control measures, including personal air exchange units, are needed for healthcare workers involved in high-risk procedures such as intubation. The mortality rate for ICU-admitted severe acute respiratory syndrome patients was over 30%, and when patients died, it was generally from multiple system organ failure and sepsis. There is no specific therapy, but anecdotal reports have suggested a benefit of the use of pulse doses of corticosteroids and ribavirin. And now we will focus on Middle East respiratory syndrome coronavirus. A new coronavirus outbreak, subsequently named Middle East respiratory syndrome coronavirus, started in September 2012 in the Arabian Peninsula. Patients presented with severe acute pneumonia, with hypoxemic respiratory and renal failure. It can occur sporadically in the community, as well as from healthcare-associated human-to-human transmission. The infection was associated with a very high fatality rate of up to 60%, especially in patients with medical comorbidities, and the majority of patients required invasive respiratory support and had extrapulmonary manifestations, mainly kidney failure. The roles of steroids, oseltamivir, ribavirin, and interferon for treatment are uncertain. We will now switch gears to bioterrorism considerations. Certain airborne pathogens can cause pneumonia as the result of deliberate dissemination by the aerosol route, in the form of a biologic weapon, and present a clinical syndrome of community-acquired pneumonia. The pathogens that are most likely to be used in this fashion and that can lead to severe pulmonary infection are Bacillus anthracis, anthrax, Yersinia pestis, plague, and Francisella tularensis, tularemia. The Centers for Disease Control and Prevention has classified these agents as Category A pathogens because of their high mortality rate and the potential impact on public health. Other pneumonic pathogens could also serve as agents of biologic warfare, but are potentially less serious and are classed in Category B and include Coxiella burnetii and Brucella species. Certain emerging pathogens are Category C agents and are not widely available as weapons, but have the potential for high morbidity and mortality, including hantavirus and MDR tuberculosis. Some agents of bioterrorism can be spread via the aerosol route, but do not generally present as pneumonia and include smallpox and viral hemorrhagic fevers, Ebola, and Marburg. We will now look at diagnostic evaluation. As discussed, the diagnosis of community-acquired pneumonia is suggested by the patient's history and physical examination and confirmed by chest radiograph. The history may suggest certain pathogens on the basis of epidemiologic considerations, as shown in Table 74.4. But the clinical features and chest radiograph cannot give an exact etiologic diagnosis. In patients with severe community-acquired pneumonia, diagnostic testing is performed to define the presence of pneumonia, the severity of illness and its complications, and the etiologic pathogen. Although defining a specific etiologic diagnosis of community-acquired pneumonia allows for focused antibiotic therapy, most patients do not have a specific pathogen identified, and many who do have this diagnosis made days or weeks later, as the results of cultures or serologic testing become available. An etiologic diagnosis is best established if blood or pleural fluid cultures identify a pathogen, if bronchoscopic techniques demonstrate an organism in high concentrations, or if serologic testing confirms a fourfold rise in titers to specific pathogens, comparing acute and convalescent samples collected weeks apart. For ICU-admitted patients, after a chest radiograph defines the presence of pneumonia, testing should include an assessment of oxygenation, pulse oximetry or blood gas, the latter if retention of carbon dioxide is suspected, routine admission blood work, and 2 sets of blood cultures, as shown in Table 74.5. Although blood cultures are positive in only 10% to 20% of community-acquired pneumonia patients, they can be used to define a specific diagnosis and to define the presence of drug-resistant pneumococci. Blood cultures are not routine for all admitted patients, but should be performed in those with severe illness, especially if the patient has not received antibiotics prior to admission, since the incidence of a true positive result is high in this population. If the patient has a pleural effusion, this should be tapped and the fluid sent for culture and biochemical analysis. Sputum culture can help to identify the presence of a drug-resistant or unusual pathogen and should be obtained from all critically ill patients who are intubated. Urine antigen test for pneumococcus or Legionella has some potential value for providing a rapid diagnosis. Legionella urinary antigen is specific to serogroup 1 infection and is positive in a little more than half of all infected patients. However, it is the test that is most likely to be positive in the setting of acute illness. Urine antigen test is also available for detecting the capsular polysaccharide of Streptococcus pneumonia and has 77% to 88% sensitivity in patients with bacteremic pneumococcal pneumonia, but only 64% sensitivity in those with non-bacteremic pneumonia. The sensitivity of pneumococcal urine antigen test increases if concentrated urine is examined, and it can be positive even in the presence of antibiotic therapy. However, false positive tests can occur in patients who have had recent pneumococcal infection. The role of Graham's stain of sputum to guide initial antibiotic therapy is controversial, but this test has its greatest value in guiding the interpretation of sputum culture and can be used to define the predominant organism present in the sample. Graham's stain can be used to broaden initial empiric therapy by enhancing the suspicion for organisms that are not covered in routine empiric therapy, such as Staphylococcus aureus being suggested by the presence of clusters of Gram-positive cocci, especially during a time of epidemic influenza. Routine serologic testing is not recommended. Nucleic acid amplification tests and PCR assays provide rapid test results in community-acquired pneumonia for atypical agents such as viruses, Mycoplasma, Chlamydophila, and Legionella. The usefulness of PCR assays in managing community-acquired pneumonia has not been proven, and the concern with this method is that it is so sensitive that, if a respiratory sample is positive, it cannot distinguish colonization from infection. However, the test may be valuable if negative, because the absence of a suspected pathogen by PCR may permit a more focused antibiotic therapy approach. Biomarkers, as mentioned earlier, are helpful in antibiotic stewardship, and a low serum procalcitonin concentration, below 0.1 microgram per liter, may be helpful to support a decision to withhold or discontinue antibiotics. Bronchoscopy is not indicated as a routine diagnostic test and should be restricted to immunocompromised patients and selected individuals with severe community-acquired pneumonia. Several studies have not shown any improvement in outcome when a specific etiologic diagnosis is made for patients with severe community-acquired pneumonia. Rather, the outcome is improved if the initial empiric therapy is accurate and the patient has prompt clinical improvement. However, Patients who have rapidly progressive lung infection, despite therapy, may benefit from invasive diagnostic testing, but again, a favorable impact of this testing on patient outcome has not been demonstrated. One population that should be considered for invasive testing is corticosteroid-treated COPD patients who have slowly responding or non-responding pneumonia, because these individuals are at risk for infection with Aspergillus, and this organism can be recovered from bronchoscopic samples. In addition, bronchoscopy may have value for the non-responding patient or other immunosuppressed individuals. In patients with severe community-acquired pneumonia, diagnostic testing may be valuable for guiding modifications of antibiotic therapy, rather than affecting the choice of initial therapy. In one study, nearly 40% of patients had no pathogens identified, and pathogen-directed therapy had no overall impact on mortality or length of stay, but led to fewer adverse events than empiric therapy, and was also accompanied by a lower mortality for patients admitted to the ICU. In addition, studies have emphasized the mortality benefit of prompt administration of effective antibiotic therapy. Thus, therapy should never be delayed for the purpose of diagnostic testing, and the diagnostic workup should be streamlined, with all patients receiving empiric therapy based on algorithms as soon as possible. Pause the video and carefully scrutinize Table 74.5 summarizing diagnostic testing for community-acquired pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 74.6 summarizing empiric therapy regimens for severe community-acquired pneumonia before advancing to the next slide. We will now discuss the treatment of community-acquired pneumonia. Initial antibiotic therapy for severe community-acquired pneumonia is necessarily empiric, with the goal of targeting the likely etiologic pathogens, based on the considerations in Tables 74.3 and 74.4, which categorize patients on the basis of the severity of illness and risk factors for specific pathogens. The likelihood of infection by organisms such as drug-resistant Streptococcus pneumoniae, enteric gram-negative organisms, and Pseudomonas aeruginosa is determined by the presence of cardiopulmonary disease or modifying factors. Although a set of likely pathogens can be predicted for each patient, as shown in Table 74.3, and this information can be used to guide initial empiric therapy. If diagnostic testing shows the presence of a specific pathogen, then therapy can be focused. In choosing empiric therapy of community-acquired pneumonia, certain principles and therapeutic approaches should be followed, as shown in Table 74.6. All individuals should be treated for drug-resistant Streptococcus pneumoniae and atypical pathogens, but only those with appropriate risk factors, see earlier, should have coverage for Pseudomonas aeruginosa, and patients with bilateral necrotizing pneumonia after influenza need coverage for community-acquired methicillin-susceptible Staphylococcus aureus. All patients admitted to the ICU require combination therapy using a beta-lactam with either a macrolide or quinolone, plus the addition of other agents, depending on the clinical setting. The recommendation to avoid monotherapy is based on the fact that the efficacy, especially for meningitis complicating pneumonia, effective dosing, and safety of any single agent, including quinolone monotherapy, has not been established for ICU-admitted community-acquired pneumonia patients. From the available data, it appears that adding either a macrolide or quinolone leads to similar results, although some data in patients with bacteremic community-acquired pneumonia, especially with pneumococcus, suggest that a macrolide may have particular advantages, possibly because of its anti-inflammatory effects. In one study of 529 patients with ICU-admitted community-acquired pneumonia, combination therapy with a beta-lactam plus either a macrolide or quinolone led to improved survival for the population with shock-needing presses, 279 patients, compared with the use of monotherapy. Another study in severe community-acquired pneumonia patients, not all pneumococcal, also confirmed the benefit of adding a macrolide as part of the initial empiric therapy, but not a quinolone, for reducing mortality. In a recent study comparing the impact of dual beta-lactam plus macrolide or fluoroquinolone, N equals 394, versus monotherapy, beta-lactam alone, N equals 471, in immunocompetent severe community-acquired pneumonia, there was no difference in the 60-day mortality between the two groups. However, there was a survival advantage for patients who had initial adequate antibiotic therapy, and those who received dual therapy had a higher frequency of initial adequate antibiotics. In one study comparing high-dose levofloxacin to a beta-lactam, quinolone combination, the single-agent regimen was effective overall. However, patients in septic shock were excluded, and there was a trend to a worse outcome with monotherapy for individuals receiving mechanical ventilation. In a meta-analysis of severe community-acquired pneumonia, the addition of a macrolide to a beta-lactam was associated with reduced mortality compared with other regimens. If Legionella is suspected, then the use of a quinolone may be preferable, since these agents have been highly successful in treating pneumonia caused by this organism and may possibly be more effective than macrolides. For patients with pseudomonal risk factors, therapy can be with a two-drug regimen, using an anti-pseudomonal beta-lactam, cefepime, imipenem C. Listatin, meropenem, piperacillin, tazobactam, plus ciprofloxacin, the most active anti-pseudomonal quinolone, or levofloxacin. Alternatively, a three-drug regimen can be used, combining an anti-pseudomonal beta-lactam plus an aminoglycoside, plus either an intravenous antipneumococcal quinolone, moxifloxacin or levofloxacin, or a macrolide. If community-acquired methicillin-resistant Staphylococcus aureus is suspected, therapy can be with either vancomycin or linezolid, although other agents might be effective, since this pathogen is not as antibiotic-resistant as nosocomial methicillin-resistant Staphylococcus aureus. However, since community-acquired methicillin-resistant Staphylococcus aureus is in part a toxin-mediated illness, the use of an agent that inhibits toxin production, along with an antibacterial effect, is recommended by some. To do this, linezolid can be used alone, since it acts to inhibit protein synthesis, or clindamycin can be added to vancomycin. Healthcare-associated pneumonia patients can be treated in the same manner as other severe community-acquired pneumonia patients, but some will need coverage for nosocomial pneumonia pathogens, including MDR gram-negatives and nosocomial methicillin-resistant Staphylococcus aureus. The benefit of a macrolide in reducing mortality may not be as dramatic in healthcare-associated pneumonia patients as in community-acquired pneumonia patients. Those who need coverage for MDR organisms are individuals with severe healthcare-associated pneumonia who have an additional risk factor, besides just residence in a nursing home, while those without such risk factors can receive the severe community-acquired pneumonia regimens. The risk factors for MDR pathogen infection include poor functional status, immune suppression, recent antibiotic therapy, or recent hospitalization. Those at risk for MDR pathogens should receive dual anti-pseudomonal therapy, beta-lactam plus an aminoglycoside, plus methicillin-resistant Staphylococcus aureus coverage, with linezolid or vancomycin. Maruyama and colleagues prospectively applied an algorithm based on the presence of MDR risk factors, immunosuppression, hospitalization within the past 90 days, poor functional status, Barthel index score below 50, and antibiotic therapy within the past 6 months, and severity of illness, requiring ICU admission or mechanical ventilation, to determine outcomes on community-acquired pneumonia and healthcare-associated pneumonia patients. Using the algorithm, the investigators used community-acquired pneumonia therapy for healthcare-associated pneumonia patients with 0 to 1 risk factors and the hospital-acquired pneumonia, abbreviated as HAP, regimen for more than 2 risk factors, but the majority, that is 92.9%, received appropriate therapy for the identified pathogens, and thus, broader-spectrum antibiotics can be potentially limited even in patients with healthcare-associated pneumonia. Although they should not be used as monotherapy for ICU-admitted community-acquired pneumonia patients, anti-pneumococcal quinolones have assumed great importance because they can cover pneumococcus, including drug-resistant Streptococcus pneumoniae, non-pseudomonal gram-negative organisms, and atypical pathogens. 1 Quinolones penetrate well into respiratory secretions and are highly bioavailable, achieving the same serum levels with oral or intravenous therapy, and thereby allowing a rapid switch to oral therapy in responding patients. The available intravenous agents that are active against pneumococcus are moxifloxacin and levofloxacin. Based on in vitro activity, the recommended doses for moxifloxacin and levofloxacin are 400 mg daily and 750 mg daily, respectively, with the need to adjust dosing of levofloxacin, but not moxifloxacin, in patients with renal insufficiency. And now we will focus on timeliness of initial therapy. For inpatients with community-acquired pneumonia, timely and accurate therapy is essential to reduce mortality. In patients with severe community-acquired pneumonia, improved survival has been shown to occur if initial empiric therapy is accurate and if it leads to a rapid clinical response. In one study, if initial therapy led to a clinical response within 72 hours, mortality of severe community-acquired pneumonia was approximately 10%. Compared with a mortality rate of 60% in patients who had initially ineffective therapy. For community-acquired pneumonia in general, early therapy is associated with reduced mortality compared with therapy given later. If the patient has pneumonia with sepsis and hypotension, mortality rises by nearly 8% for every hour of delay in starting therapy. We will now discuss the duration of therapy. There is little information on the proper duration of therapy in patients with community-acquired pneumonia, especially those with severe illness. Even in the presence of pneumococcal bacteremia, short durations of therapy may be possible, with a rapid switch from intravenous to oral therapy in responding patients. Generally, Streptococcus pneumoniae can be treated for 5 to 7 days if the patient is responding rapidly and has received the correct dose of an accurate therapy. The presence of extrapulmonary infection, e.g., meningitis, and the identification of certain pathogens, such as bacteremic Staphylococcus aureus and Pseudomonas aeruginosa, may require a longer duration of therapy. Identification of Legionella pneumophila pneumonia may require at least 14 days of therapy, depending on the severity of illness and host defense impairments, but shorter durations with quinolone therapy have been shown to be effective. Most therapy in the ICU will be given intravenously. However, recent studies, using a variety of antibiotics, have suggested that oral therapy may be instituted after as early as 2 to 3 days of parenteral therapy, assuming that the patient's condition has stabilized and the patient is afebrile. The switch to oral therapy, even in severely ill patients, may be facilitated by the use of quinolones that are highly bioavailable and achieve the same serum levels with oral therapy as with intravenous therapy. The initial procalcitonin level may accurately predict a positive blood culture in pneumonia patients, and serial measurements help with antibiotic de-escalation and withdrawal in community-acquired pneumonia patients. In a randomized trial of antibiotic therapy in the ICU, procalcitonin guidance led to a reduction in the duration of therapy compared with standard care in all patients, including those with severe community-acquired pneumonia. A recent meta-analysis of 14 randomized trials favored a procalcitonin-based treatment algorithm for antibiotic de-escalation without an increase in either mortality or treatment failure. We will now discuss adjunctive therapy measures. In addition to antibiotic therapy, patients with severe community-acquired pneumonia may require chest physiotherapy, especially if they have either an excessive volume of purulent sputum, that is more than 30 milliliters per day, or severe respiratory muscle weakness resulting in ineffective cough. Aerosolized humidification has been used to reduce sputum viscosity, thereby enhancing clearance in patients who have generally ineffective cough. However, it is likely that much of the generated water vapor is deposited in the upper airway, where it is likely to stimulate cough, but unlikely to influence the rheologic properties of the sputum. Bronchodilator therapy, which also enhances mucociliary clearance and ciliary beat frequency, is most likely to be of benefit in patients with pneumonia complicating COPD. A recent Cochrane review did not find convincing evidence supporting the role of chest physiotherapy in pneumonia patients. Previous studies looking into the use of adjunctive corticosteroids in patients with severe community-acquired pneumonia have shown mixed results. Although the role of corticosteroids in the routine therapy of community-acquired pneumonia is not established, steroids may be beneficial in patients with sepsis and relative adrenal insufficiency, which occurs in a high proportion of patients with severe community-acquired pneumonia. A recent meta-analysis of 9 trials involving 1,001 patients did not support the routine use of corticosteroids in community-acquired pneumonia patients, but showed that it may improve mortality in a subset with severe community-acquired pneumonia. Another setting in which corticosteroids may have benefit is in pneumococcal pneumonia that is complicated by meningitis, where pre-treatment with corticosteroids prior to antibiotic therapy may lead to more favorable neurologic outcomes. Recently, Torres and Associates, in a randomized, prospective study, found that in patients with severe community-acquired pneumonia and elevated C-reactive protein greater than 150 mg per liter at admission, administration of intravenous methylprednisolone, bolus of 0.5 mg per kilogram per 12 hours, led to less treatment failure compared with placebo. In that study, there was no significant difference in hospital mortality between the two groups. Adjunctive immune therapy with granulocyte colony stimulating factor has also been used in severe community-acquired pneumonia, with no benefit in mortality or in the course of illness resolution. We will now discuss the evaluation of response to therapy. The majority of patients will respond rapidly to accurate empiric therapy within 24 to 72 hours. Clinical response is defined as improvement in the symptoms of cough, sputum production, and dyspnea, along with the ability to take medications orally, declining white blood cell count, and an afebrile status on at least 2 occasions 8 hours apart. In the critically ill patient, Improvement in oxygenation may be one of the earliest signs of response to therapy, although few studies have examined mechanical ventilation patients. Radiographic improvement lags behind clinical improvement and, in general, 50% of patients with pneumococcal pneumonia have radiographic clearing at 5 weeks, whereas the majority clears in 2 to 3 months. With bacteremic disease, 50% of patients have a clear chest radiograph at 9 weeks, and most are clear by 18 weeks. Radiographic resolution is most influenced by the number of lobes involved and the age of the patient. Radiographic clearance of community-acquired pneumonia decreases by 20% per decade after the age of 20 years, and patients with multilobar infiltrates take longer to clear than those with unilobar disease. If the patient fails to respond to appropriate therapy during the expected time interval, then it is necessary to consider infection with a drug-resistant or unusual pathogen, such as tuberculosis, Coxiella burnetii, Burkholderia pseudomorle, Chlamydia psittaci, endemic fungi, or hantavirus, a pneumonic complication, lung abscess, endocarditis, empyema, or a non-infectious process that mimics pneumonia, bronchiolitis obliterans with organizing pneumonia, hypersensitivity pneumonitis, pulmonary vasculitis, bronchoalveolar cell carcinoma, lymphoma, pulmonary embolus. The evaluation of the non-responding patient should be individualized, but may include CT of the chest, pulmonary angiography, bronchoscopy, and, occasionally, open lung biopsy. We will now switch gears to the prevention of community-acquired pneumonia. Prevention of community-acquired pneumonia is important for all population groups, but especially the elderly patient, who is at risk for both a higher frequency of infection and a more severe course of illness. Appropriate patients should be vaccinated with both pneumococcal and influenza vaccines, and cigarette smoking should be stopped in all at-risk patients. Even for the patient who is recovering from community-acquired pneumonia, immunization while in the hospital is appropriate to prevent future episodes of infection, and the evaluation of all patients for vaccination need and the provision of information about smoking cessation have been performance standards used to evaluate the hospital care of community-acquired pneumonia patients. We will now discuss pneumococcal vaccine. Pneumococcal capsular polysaccharide vaccine can prevent pneumonia in otherwise healthy populations, as was initially demonstrated in South African gold miners and American military recruits. The benefits in individuals of advanced age or with underlying conditions in non-epidemic environments are less clearly defined. The polysaccharide vaccine efficacy has ranged from 65% to 84% in patients with diabetes mellitus, coronary artery disease, congestive heart failure, chronic pulmonary disease, and anatomic asplenia. In immunocompetent patients over the age of 65 years, effectiveness has been documented to be 75%. In the immunocompromised patient, effectiveness has not been proven, and this includes patients with sickle cell disease, chronic renal failure, immunoglobulin deficiency, Hodgkin's disease, lymphoma, leukemia, and multiple myeloma. A single revaccination is indicated in a person who is older than 65 years of age, who initially received the vaccine more than 5 years earlier and was younger than 65 years of age at the first vaccination. If the initial vaccination was given at the age of 65 years or older, a repeat vaccination is not indicated unless the patient has anatomic or functional asplenia or has one of the immunocompromising conditions listed earlier. In these patients, revaccination is indicated, and the second dose is given at least 5 years after the original dose. The available polysaccharide pneumococcal vaccine is widely underutilized, especially as the 23-valent pneumococcal vaccine contains 23 pneumococcal serotypes that cause 85% of all infections due to pneumococcus. 2 protein-conjugated pneumococcal vaccines have been licensed, and are more immunogenic than the older vaccine, but contain only 7 and 13 serotypes. However, the conjugate vaccine has had benefit for adults, even when given to only children, demonstrating a herd immunity effect. The 13-valent pneumococcal conjugate vaccine, abbreviated as PCV13, was approved by the Food and Drug Administration in late 2011 for use among adults aged equal to or greater than 50 years. Based on the recent report from the randomized, placebo-controlled trial evaluating the efficacy of PCV13 for preventing community-acquired pneumonia among adults aged equal to or greater than 65 years, CAPITA, Community-Acquired Pneumonia Immunization Trial in Adults, the Advisory Committee on Immunization Practices recommended routine use of PCV13 among adults aged community-acquired pneumonia 65 years from August 2014. PCV13 should be administered in series with the 23-valent pneumococcal polysaccharide vaccine, giving PCV13 first, if possible. PCV13 and 23-valent pneumococcal polysaccharide vaccine vaccination are also recommended in patients with chronic pulmonary diseases on steroids or receiving immunomodulating therapy or who have concurrent sickle cell disease or other hemoglobinopathies, primary immunodeficiency disorders, HIV infection, AIDS, nephrotic syndrome, and hematologic or solid malignancies. Hospital-based immunization could be highly effective, because over 60% of all patients with community-acquired pneumonia have been admitted to the hospital, for some indication, in the preceding 4 years, and hospitalization could be defined as an appropriate time for vaccination. Pneumococcal vaccine can be given simultaneously with other vaccines, such as influenza vaccine, but each should be given at a separate site, and the vaccine can, and often should, be given before discharge in the patient admitted for community-acquired pneumonia. Next we will discuss influenza vaccination. Influenza epidemics contribute to both morbidity and mortality by causing direct infection and by leading to post-influenza complications. The influenza vaccine preparations are revised annually to account for changes in the antigenic nature of the virus, antigenic drift, that occurs each season. 3 strains are represented in each vaccine preparation. 2 influenza A strains, H3N2 and H1N1, and 1 influenza B strain. Vaccination should be given to all patients older than the age of 65 years and to those with chronic medical illness, including nursing home residents, and to those who provide health care to patients at risk for complicated influenza. It is given yearly, usually between September and mid-November. While the traditional influenza vaccine contains an inactivated virus, there is now an intranasal vaccine containing a live attenuated influenza virus. It is currently approved for individuals aged 5 to 49 years who are not immune suppressed or chronically ill and who do not have asthma. When the vaccine matches the circulating strain, it can prevent illness in 70% to 90% of healthy persons younger than the age of 65 years. For older persons with chronic illness, the efficacy is lower, but the vaccine can still attenuate the influenza infection, lead to fewer lower respiratory tract infections, and reduce the associated morbidity and mortality that follow influenza. In many studies, The vaccine has been shown to be cost-effective and able to prevent severe illness and death and to reduce the occurrence of secondary pneumonia and hospitalization. For those above 65 years of age, a higher dose influenza vaccine, dosed at 60 micrograms of hemagglutinin per strain, has been shown to provide better protection. In a randomized study including 31,989 participants, the high-dose vaccine induced significantly higher antibody responses and provided better protection against laboratory-confirmed influenza illness than the standard vaccine. In another study, Azurieta and colleagues, from a large Medicare database of participants aged equal to or greater than 65 years, found that those who had received high-dose inactivated influenza vaccine during the 2012-2013 influenza seasons were less likely to have influenza-related medical encounters and hospitalization than those who had received the standard dose vaccine. Finally, we will consider a few key points. 1. Community-acquired pneumonia is a common illness, but only about 20% of all affected patients are admitted to the hospital, and only 10% to 20% of admitted patients require ICU care. 2. Risk factors for severe community-acquired pneumonia include smoking, alcohol abuse, serious comorbid medical illnesses, and advanced age. 3. Risk factors for community-acquired pneumonia mortality include severe physiologic abnormalities, delays in the initiation of appropriate antibiotic therapy, advanced age, genetic abnormalities in the immune response, rapid radiographic progression, the development of respiratory failure, and the presence of certain high-risk pathogens. 4. Prognostic scoring systems are useful for predicting community-acquired pneumonia mortality, but are less accurate for identifying patients who require ICU care. ICU care is needed for patients with respiratory failure, multilobar infiltrates, severe hypoxemia, PaO2 to FiO2 ratio less than 250, and systolic blood pressure lower than 90 mm of mercury. Early recognition of severe community-acquired pneumonia may allow the ICU to be used in a fashion that can reduce the mortality of this illness. 5. The failure to localize infection to a single site in the lung, with excessive systemic and pulmonary inflammation, is a common feature in patients with severe forms of community-acquired pneumonia. 6. The clinical features of pneumonia cannot help to predict the microbial etiology, especially in older patients with impaired immune response, who commonly have less dramatic clinical findings than younger patients with a similar severity of illness. 7. The most common pathogens causing severe community-acquired pneumonia include pneumococcus, atypical pathogens, Legionella species, Mycoplasma pneumoniae, and Chlamydophila pneumoniae, enteric gram-negatives, including Pseudomonas aeruginosa, Staphylococcus aureus, including community-acquired methicillin-resistant strains, and Haemophilus influenza, but infection can also be the result of viral illness, influenza, severe acute respiratory syndrome, bioterrorism, anthrax, and other miscellaneous organisms. 8. Antibiotic-resistant pneumococci are increasingly common and must be considered in the choice of initial antibiotic therapy for severe community-acquired pneumonia, but the impact of resistance on the outcomes of patients is uncertain. 9. It may be difficult to establish an exact etiologic diagnosis in patients with severe community-acquired pneumonia, but diagnostic testing should always include a chest radiograph, oxygenation assessment, blood cultures, and, in selected patients, sputum grams stain and culture, bronchoscopic culture, and urinary antigen testing for Legionella and pneumococcus. 10. Therapy for severe community-acquired pneumonia must be administered promptly and empirically, using multiple antibiotics directed against pneumococcus, atypical pathogens, enteric gram-negative organisms, and, in some patients, Pseudomonas aeruginosa and community-acquired methicillin-resistant Staphylococcus aureus. This usually requires the combination of a specific beta-lactam with either a macrolide or a quinolone and sometimes the addition of other agents. Quinolone monotherapy is not recommended for the empiric management of severe community-acquired pneumonia. In patients with severe community-acquired pneumonia after influenza, community-acquired methicillin-resistant Staphylococcus aureus should be considered. 11. Biomarkers such as procalcitonin may help identify bacterial infection, and serial measurements will help with antibiotic stewardship. 12. Non-response in severe community-acquired pneumonia can be recognized as early on as 24 to 48 hours and requires consideration of unusual or drug-resistant pathogens, non-infectious diseases that mimic pneumonia, and pneumonia complications. 13. Prevention of pneumonia can be accomplished by focusing on smoking cessation and immunization for pneumococcus and influenza, with consideration of a hospital-based immunization program. The 13-valent pneumococcal conjugate vaccine, abbreviated as PCV13, was approved by the Food and Drug Administration in late 2011 for use among adults aged equal to or greater than 50 years, and recent evidence suggests using PCV13 in series with the 23-valent pneumococcal polysaccharide vaccine among patients equal to or greater than 65 years of age. Thank you.